I am presenting today about indication of cervical total disc arthroplasty. This is the agenda of what we are going to be talking about today. First of all, before I talk about cervical disc arthroplasty, let me talk a little about ACDF as an introduction, which is relevant to the discussion of cervical disc arthroplasty. Why people are using this ACDF is that it's commonly described as the gold standard in terms of treating cervical degenerative pathology. That is because it's a highly reliable procedure. This is a study that was published in Spain a couple years ago, looking at outcomes over 10 years of 159 patients who underwent ACDF at a single institution, looking at VAS, NDI, and the patient's assessment of procedural success. You can see at 10 years that passes the procedure, reported success on the patient side was 85 to 95%. However, 10% did require early surgery for shoulder arthrosis, and at 21% had undergone revision for ASD. And you can see the relationship that graph down at the left is demonstrating time and the percentage of patients who underwent adjacent segment surgery. So while ACDF is a reliable surgery, its not without its flaws. This is a biomechanical study, and they reported that plate fixation at C5-6 increased intradiscal pressure by 73% at C4-5 and 45% at C6-7 and increased mobility. This is a kind of landmark paper looking at 374 patients, 409 fused level, followed up to 21 years, and the incidence of symptomatic ASD for the first 10 years was about 2.9% per year. Interestingly, the study found that multi-level ACDF had a lower ASD risk than a single-level procedure, and they identified pre-existing degenerative change at the adjacent level, as well as fusion involving C5 or C6 being specific risk factors for the development of ASD in the setting of an ACDF. This is MRI study whether the degeneration in these adjacent segments was induced by the fixation or occurred during the natural course is a matter of debate. In a 10 years longitudinal study using MRI, they reported that ACDF patients had higher incidence of progression of disc degeneration at adjacent segments than healthy people. Then cervical disc arthroplasty was developed to preserve the mobility and to prevent ASD. Mechanical studies have reported no increase in intradiscal pressure or range of motion in adjacent levels underwent CDA. The history of cervical disc arthroplasty, it started back in the 60s. There was a Swedish orthopod whose name was Dr. Franström, who created and designed this Franström ball for both cervical and lumbar indications. You can see some X-rays of it here. It was implanted through posterior approach and mostly due to implant subsidence as well as displacement, results were not particularly good. In the 80s, the Cranes Bristol disc, it was developed at French in the Bristol in the UK. It was a metal-on-metal ball and socket design, and the attempt was to allow range of motion with preventing some of the subsidence concerns that had been brought to light with earlier clinical ball design. Clinical trials began in the 90s and they published their initial results in 1998. This was notable complications with dysphagia and screw pull-out, some of which were attributed to the size of the implant. But this was kind of the advent of what is now the modern cervical disc arthroplasty. The rights to these Bristol Cummins were subsequently purchased by Medtronic and became what's known as the Prestige. And this was the first FDA IDE trial that began in 2002 with approval for single level given in 2007. Subsequently, two-level use has also been approved. This is the most common indications across CDA devices, and single or two contiguous levels between C3 and C7 for conditions intractable radiculopathy and or myelopathy, and at least one of the following: herniated nucleus pulposus, spondylosis, visible loss of disc height, and skeletally mature patient, and failure of 6 weeks of conservative care. This is the common contraindications of the approved US IDE CDA devices: neck pain only, prior surgery at the index level, segmental instability, severe spondylosis, disc height less than 3 millimeters, severe facet joint degeneration, significant kyphosis, compromised vertebral body, and osteoporosis. We are going to move on now to the outcomes and complications. The question is, how is the patient outcomes compared to ACDF, which is, as I already mentioned, a very reliable solution to the degenerative cervical change, but also more importantly, the benefit of changing over to this relatively new technology is whether cervical disc arthroplasty reduces the risk of adjacent segment disease compared to ACDF. And I'll get in some of the studies. Hopefully, I'll give some answers to this. This was a study that was published in Spine in 2013. It was a Cochrane database review, and it was based only on 2-year data, but it was 9 studies and 2,400 patients, and you can see the primary and secondary outcomes listed there. Mostly similar is I'm going to be presenting because there are the criteria that were used to demonstrate non-inferiority in the IDE trials: neck pain vs. patient satisfaction, patient outcomes, as well as neurological complications. And I highlighted some of the points that a relevant difference was not seen for primary outcomes although there may be some trend towards some superiority and certain of these outcomes for arthroplasty. And the key point from this study is that final breadth essentially highlighting the fact that looking at 2-year outcomes for this procedure when you are really examining not only patient outcomes, but more importantly, the development of adjacent segment degeneration. It's tough to assess that at 2 years. This is looking at the follow-up IDE comparative study. These are the outcomes that they looked at: NDI, neurostatus, disc height, need for additional surgery, and adverse events. And at the 10-year time point, you can see 10% had undergone revision surgery at index level, 13% at adjacent level, and 9% had developed class 4 heterotopic ossification, which I'll get to later again, but that shows complete loss of motion. This is now getting into two levels. This study showed that there was some angular range of motion maintained at the superior and inferior levels versus what would typically be seen in an ACDF with a fused level. And they found against NDI overall success and neurologic success, as well as non-inferiority to neck and arm pain, with significantly fewer second procedures at the index level. This is 10-year follow-up data from the previous slide, were available on 148 CDA and 118 ACDF patients. CDA maintained improved clinical outcomes and segmental motion and fewer second surgical procedures at the index and adjacent levels, even at 10 years. This is looking at the outcomes of hybrid surgery combining CDA with fusion. Hybrid showed better NDI, more preservation of cervical range of motion, and lower adjacent segment range of motion. There was no RCT in this paper, but there may be more cases and more papers on hybrids in the future. This is meta-analysis published in 2018, and their meta-analysis looked at short to medium-term follow-up, so up to 7 years, and they found that there was significant improvement in NDI, SF36, dysphagia, and satisfaction between 4 to 7 years. This is another meta-analysis published in 2020, and their meta-analysis looked at minimum 4-year follow-up, and they found that there was significant improvement in NDI, SF36, as well as lower secondary surgical procedure. And these are complications of CDA. Because of the common anterior approach used, complications specific to CDA are relatively rare. In this list, I would like to focus on adjacent segment degeneration and heterotopic ossification. This is the Prestige implanted 7 years cumulative rates of index surgery requiring revision were statistically significant lower as well as adjacent levels. You can see it's roughly about a half to one-third rate at that time point. This was published in 2016, looking at 2 to 7 years, nothing beyond that, but trying to find out rather than looking at ASD, but using the rate of reoperation as a marker for the development of adjacent segment disease, overall fewer secondary surgeries, both at the index as well as adjacent level, based on this meta-analysis. This paper evaluated adjacent segment degeneration and adjacent segment disease separately. The rate of adjacent segment degeneration and adjacent segment disease of CDA were significantly lower based on this meta-analysis. And so a lot of these studies, both single level as well as multi-level, seems to indicate that there is a lower rate of ASD comparing ACDF. And one of the problems I already mentioned based on what was published before was development heterotopic ossification, at least with the early implants in earlier studies. And this is a complication that is commonly seen. And this is a great grading system from modified McAfee, looking at how to classify the degree of heterotopic ossification as grade 3 or 4 heterotopic ossification can limit the range of motion of the implantation segment and may influence the clinical outcomes. And while two-thirds of the patients in the series had some degree of HO, only 10% had some sort of motion restriction. And going beyond that to another meta-analysis looking at the prevalence of HO of 53% at 5 to 10 years based on this meta-analysis looking at 38 studies, but severe HO defined as grade 3 and higher was close to 48% at 5 to 10 years. This was published in 2021. 83% patients were extracted from previous RCT and looking at 2 and 5 years. They showed the prevalence of HO of 92% and severe HO of 71% at 5 years. Some additional outcomes that were referenced or compared in those IDE studies. It's an AO spine study in the Global Spine Journal that attempted to do a meta-analysis looking at safety and efficacy of total disc arthroplasty, comparing it to ACDF. In addition to HO, looked at dysphagia, death, secondary surgeries, and neurologic injuries. And you can see that slight favoring wound-related complications for ACDF, but surgical-related neurologic events and secondary surgeries were significantly fewer in CDA. Next step for directions for research or investigation is that what is known about this implant is based on the data that's been taken out from the patients in the initial FDA IDE trials. And the studies that are published in terms of looking at patient outcomes for multi-level are very heavily weighted towards two levels, so it makes it difficult to draw any conclusions regarding the safety or efficacy for greater than two levels. And the definitions of success, they looked at the instance of either index or adjacent level reoperation, not necessarily the instance of adjacent segment degeneration. So research needs to be adapted rather than looking at the not just the instance of surgery, but that this from a radiographic standpoint actually reduce the instance of adjacent segment degeneration or disease. In summary, ACDF is a highly reliable procedure that has a history of good outcomes. On the other hand, every procedure has complication and adjacent segment disease is non-complications. Cervical disc arthroplasty out to 10 years, it seems to indicate, particularly with single to two levels, that the patient outcomes in terms of NDI as well as patient satisfaction and VAS for arm and neck at least equivalent to ACDF. And there are studies that have looked specifically at ASD, as well as the more extensive list of studies that have looked at the reoperation rates at index as well as adjacent levels. And there seems to be some indication that the cervical disc arthroplasty may be able to deliver on decreased risk of clinically significant degeneration from adjacent to the treated level. And the rate of heterotopic ossification is quite high, and something to bear in mind when you are doing your own risk-benefit calculations and counseling your patients. Thank you for listening to my presentation.
Great dive into that topic, Hiroto. It's a tough one. What were your thoughts looking through the articles about how we really apply these RCTs to our practices with the following challenge in mind? Most of those studies with the RCTs have very, very strict guidelines or inclusion and exclusion criteria for doing these disc replacements, number one. Number two, the ACDFs are usually, at least in my memory, allograft and plate, and so not necessarily exactly how we practice now. So they're not necessarily apples to apples comparisons. And again, the indications for the CDRs are very tight. So I struggle in my practice applying that with all that data in mind, without applying those same strict criteria to the patients that I indicate for a CDR. Any questions about that? Or the other challenge is all the patients come in wanting a CDR and very few fit those criteria. So you look at those numbers and you talk to patients about the numbers in those studies, but the reality is most of the patients you see don't fit those criteria.
Yeah.
So anybody else have any input on that? Greg, Hanny, Jamie?
Yeah, Bob, I agree with you. I think we look at those and we have to really be careful with the data sets versus what our patients really have when they come to see us. Because we've all seen the failure of the disc replacement where we thought we had done everything right and it didn't work. Probably because the indications weren't strict enough, maybe.
Right.
Yeah.
Hmm.
Yeah, it's almost, when they did the RCTs, Hirota, as you know, they kind of cherry pick the best quality patients, rightfully, so that they're more likely to see a differential between the two types of surgeries. I'm not so sure those numbers would hold up if it was more liberally applied. Might be a little more equitable between the two. But if you look at the meta-analyses and the big RCTs that are very good quality studies, you get this sense that there's no question CDR is better. I think the most important message is, especially for the younger folks and the fellows, you can't apply those numbers across the board to all your patients you're going to see that have cervical pathology for which you might consider either. You have to be a little more selective, a lot more selective, really.
Hmm.
Well, excellent job. Any other questions, fellows?
I was going to ask, what are the kind of, I guess, inclusion criteria that they used in those studies that you're seeing the problems with kind of in the clinic more? Not meeting, I guess.
Most of the FDA trials, these big randomized trials, had inclusion criteria and exclusion criteria that were limiting the disc height loss to less than 50%, no facet arthritis, and I believe there was a restraint on bony resection and spondylosis that would require significant bony resection. So I'm not sure that was quantified very well, but the main ones were the disc height loss relative to adjacent levels or normal levels.
Okay.
Which you'll you implies a lot more spondylosis is present. So there's shades of gray in there, but FDA trials are almost always very well cherry picked because especially with new technology, companies that set up these trials very much want to see a difference, and so they're gonna stack the methodology in a manner that does the best it can at differentiating the old versus the new technology. And that's while that's reasonable, it leaves a bit of a chasm in terms of applicability broadly to your practice and to your patients. So I think really cool, important next questions are, and he presented one: how does hybrid work? They never really did that in a controlled randomized trial fashion, or how do these disc replacements stack up against ACDF in a little more spondylotic environment? Are they equivalent? Are they worse? Where can we start expanding the indications? And I think you see that here. I mean, that we're not doing a ton of CDRs, but you go to Cedars-Sinai or that Beverly Hills crowd. I mean, they're cranking these CDRs out like crazy, and lumbar discs too, by the way. So,
Bob, do you think any major difference in the types of CDRs that are available today, or
say that again, Bruce? What was that? Sorry.
The type of implants, the different devices that are available. Are there any major difference, or pretty much all the same, almost?
No, I think there's differences. There are different constraints. So the mechanical behavior, the kinetics of the implants vary, and that's another big unknown. Are there better places to use more mobile, less constrained implants, and other places to more wisely use more constrained implants? Yeah, and I think as we, if we can somehow study that, we might find that we can do disc replacements in more spondylotic environments with a particular type of biomechanics versus an alternative type.
Yeah.
really interesting question. So I don't have the answer, but definitely, and it's not low-hanging fruit. Those are tough studies, but really interesting questions to answer. Same with the lumbar discs. You know, those have changed over time as well. And I don't know, honestly, where we will go with those over time. I think they're a little more. It's just a tougher environment in general because of the indications, but both have a role for sure.
Nice presentation, Hiroto.
Oh, thank you.